to initiate. Well, it's fascinating. The article is. I'll be looking forward to hearing what the authors have to say and how it's going to be critiqued. It's a wonderful article to look at critiquing. And I was reflecting today just how far the Asia Pacific Endodontic Confederation has progressed now. And thanks to you, Professor Nekufar, to take it virtually to another level. We were wondering how we're going to get articles published, and now you're taking it to the world. Thank you very much. Thank you very much.
Thank you very much, Phil. But that's my honor, actually, because you are one of the pioneers of Asian Pacific Endodontic Confederation. This is great to have you with us. Honestly, without this type of support, I don't find enough energy to go ahead. But this is amazing to have this support. Thank you very much indeed. And let me ask Professor Sanjay Miglani, the Dean of the Educational Committee, to has his talk. It seems he's driving. Be careful, Sanjay.
Hi, how are you?
Thank you very much.
You know, in Delhi, this is the time of festivals. Diwali is just around the corner, and it is like a Christmas for us. So the roads are packed. It took me 2 hours to go back from my school to my home.
Okay.
So anyway, my best wishes. Maybe I have the speakers, and I think they'll do justice with their paper. Thank you so much.
Thank you very much. And stay with us, Sanjay. Professor Sanjay Miglani is also the ex-president of Asian Pacific Endodontic Confederation. And also now he is the Dean of the Educational Committee. We have different types of colleagues from around the world. We have Professor Uzgur İlke Ulusoy, the Secretary of the Educational Committee, Professor Al-Hawaizi, the President of the Iraqi Association of Endodontists. From around the world, we have a lot of you. Thank you very much for joining. And now I'm happy to say that Professor Mannocci also joined us. So Professor Mannocci, hello, good evening. Hello. And thank you very much for accepting our invitation to discuss about your article.
Right.
If you want to have some word, please go ahead. And then I am going to ask Dr. Fatema Betul Baştürk to start her PowerPoint.
Okay, no problem. Thanks very much for the invitation. It's a pleasure. It's a pleasure to see some familiar and less familiar faces around. And let's carry on. Thanks for the invitation. It's a pleasure to have some contact with the Iranian dentists, which we normally don't have much contact with. So it's a good thing.
Oh, thank you very much. Let me correct you. Actually, this is a session support and run by Tehran University of Medical Sciences. Obviously, on behalf of them, I am doing that. But this is based on the contract that we at Tehran University of Medical Sciences have with Asian Pacific Endodontic Confederation,
all right,
which is APEC. And we have the Dean of the Educational Committee with us, and also the President will join us as well.
Right.
And so far, actually, we had more than 23 sessions with the participation of more than 3,000 participants from 57 countries in this particular virtual program.
Right.
So thank you very much. What we did actually so far, we invite the authors, first author, corresponding authors of different topics, hot topics of endodontics, and ask one of our colleagues to critically appraise that article and discuss the topic in the presence of the authors, which becomes very popular and very attractive to different authors from around the world. Thank you very much. So I'm going to ask Dr. Fatema Betul Baştürk from Turkey. She's actually a colleague from Turkey that is going to present your article to the participants, and she will ask you some questions. And please accept our apology because the goal of this session is discussion. For example, I know some of the professors here, Professor Vladimir, who taught this topic for more than 30 years in his university. Obviously, he's going to have a lot of questions, a lot of comments, and some of them sometimes is going to be directly about your publication as well. Okay, Fatima Batul Dashturk, we all ears.
Right.
Hello, and it's very great honor and privilege to be actually being the appraiser to Professor Mannocci's article. For years, I read Professor Mannocci's lots of articles because I had a conjoined PhD in endodontics and in restorative dentistry. So all the topics that he's talking about are the main problems, the main concerns that we have in the clinics. And thank you once again for the great articles and great reviews. And hopefully I have so many questions to direct to you, and hopefully we will have a fruitful discussion. So Professor, I'd like to do the screen sharing first.
Yeah.
And we're going to. All right. Is it on?
Yeah.
Okay, that's perfect. So this is a poster for today's session. And for those who haven't had opportunity to read the article, actually the article's name is this: Present Status and Future Directions, the Restoration of Root-Filled Teeth. So once again, we're very privileged to have Professor Mannocci himself. As we all know, the almighty Professor Nekufar is the moderator, and I'm going to be the appraiser today. Mainly, the whole paper is about the management strategies for root-filled teeth for long-term survival. So actually, we know that we have the causes of failure for root-filled teeth. Mainly, most of the articles in endodontic journals focus on the biological aspects, the persistent or recurrent diseases, the periodontal diseases, but actually, structural problems are the problems that we face in the clinics. So these are the restorative failures, irretrievable cusp or crown fracture, and vertical root fracture. Recently, we actually come across with a lot of articles about post-pandemic vertical root fractures, post-pandemic restorative failures due to a lot of bruxism, a lot of clenching. So mainly, today, I'm hoping to have a little bit of a chat with all you respected authors. As I read the article, I decided to give the subheadings because the subheadings are actually quite well established in the article. So it starts with the present status and goes to the future implications of what we can do in the restorative clinics. So we're basically going to start with the present status for the restoration of root-filled teeth. The main thing is that there is a lack of guidance. So we actually do not have a specific guidance for what we should do when we deal with teeth who might require cuspal coverage, or we have no idea when we start doing the root canal treatment about the type of restoration or the timing of placement of the definitive restoration. So what I want to ask you first, Professor, should or must an endodontist do the restoration of the tooth that he or she started doing the endodontic treatment to?
So are we talking about, do you mean the preparation of a core or the full crown or only? So what is your question? Both actually,
because yeah.
It depends.
Please,
It depends. There are, I mean, when we say the word endodontist, we say a word which is obviously confusing in itself, because the country I come from, which is Italy, for example, does not recognize endodontics as a separate specialty. So if we talk about the countries where endodontics is a specialty, let's say United Kingdom or United States or other countries in the world, then obviously the endodontist, which receives a patient from another dentist, can ask the other dentist if it's possible to do the coar. The coar obviously would always be best done by the endodontist, no, because the endodontist already has the access to the root canal. If you can do your coar, then it's the best situation. You can avoid contaminating the surface of the coar with any material that may create problems for the bonding, for example. So clearly, if you are a specialist endodontist in a country where that is a specialty, or if you got a pool of referral dentists which trust you as an endodontist but want to do the crown, then doing the coar would be the ideal situation. And then if you live in a country where there is no specialty, and obviously you are there and your colleagues or your patients are happy for you to provide the crown, and you've got the skills to provide the crown, there's nothing wrong with doing that.
So what I'm wondering, actually, I see that there are many participants from all around the world. I'm wondering what is the main thing about, is endodontics a different specialty, or is it combined with the restorative dentistry? Because in about 10 years ago,
let's ask others to give us some comment, Fatima. Vladimir, what do you think?
I would be grateful.
Considering what endodont, so we have a specialization of restorative and endo for almost 40 years, but we are not recognized by European Society of Endodontology for many, many reasons. I would like to stress on the point that our national pathology is that almost at least 2/3 of teeth that are treating endodontically are for full crown restoration. I mean, for build up and restoration with full crown, because the original tooth crown is almost damaged or with no resistance form, no retention form, and most of endodontist specialists are making either post and coronal restoration, but not crown, just build up, core build up, or just leave the space, prepare the space for the prosthodontics to make, to produce good root canal retention. Because if we send without any preparation of the root canal that we have been treating, then very often prosthodontics make a mistake, either false root or some misleading way through, not through the obturation, but through the root.
Thank
you. That's the point, that we all teach our specialist trainees either to prepare the post space or to do the post and coronal build up. And then
thank you, Vladimir. Because of the time, I want to ask two more participants to give us an idea. Paul, what do you think? Please introduce yourself and tell us about your country as well, for others that they don't know you very well. And then you can go ahead and give us your comment.
Well, I'm Paul Lambrechts from the Catholic University of Leuven in Belgium. And in our country in Leuven, endodontology is a specialty and restorative dentistry is a specialty. But I'm aware that there are a lot of common procedures like field isolation, rubber dam placement, the use of microscopes, adhesive dentistry, or if you use it in cavities or in class 5 lesions or intracoronally or in the canal, it are in fact the same concepts and procedures. So it is wise if the endodontologist in the same session of the endodontic procedure, when everything is under control, can make the post and the coronal seal. nowadays also endodontologists have CAD/CAM systems in their practices, like CEREC devices, so they can make an intracoronal endodontic obturation, and that's always the best for the tooth. Of course, then you don't wait for the healing of the periapical lesion, but if we have to wait 1-2 years for the healing, then the tooth already can be fractured. So I certainly advise the faster as possible you have to place the coronal restoration on top.
Thank you very much. Professor Zimmet, what is the situation in Australia? Is it same as we discussed already, or
Are different specialties?
Unmute yourself. Please unmute yourself. Professor Zimmet, we cannot hear you.
There are, it's very segmented and very fragmented in Australia. So at my university, for example, the coronal restoration is an integral part of the root canal treatment. Wow. There are other universities where, following the root canal treatment, the patient may get a core which will function as the support for a cast restoration. But at my university, we subscribe to the concept where we have a phased treatment. The phased treatment starts with the disease control phase, where we have the root canal treatment, wait for periapical healing, which can take some time. But in the meantime, we're going to put a direct placement composite restoration over the tooth, which will function both to protect the tooth and to preserve the root canal treatment as well, with recognizing that ultimately a lot of the failure of these direct placement restorations is not catastrophic. It's just ultimately a lot of these restorations will chip, and they will require some intervention. But so, depending on who you speak to, will depend on the direct outcome following the actual root canal treatment.
Thank you very much. Fatima, please carry on.
Okay. So my first question, one of the first questions actually, is about the search terms, because I read the article and there is no specific part in which explains how you decide on the search terms. Professor Mannocci, can you tell us when you start writing or making a review article, how do you decide what to search?
Yeah,
before Professor Mannocci answered this question, let me explain the reason of this question. Because in this discussion, we don't just discuss the topic. We like actually to discuss the methodology, because we have a lot of postgraduate students with us. So it is also a teaching session for them as well. Thank you very much, Francesco, please.
Yeah, no, it's a very good question. So, first of all, I've never done systematic reviews myself. So these two reviews we've done on restoration of endodontically treated teeth are not by any means systematic reviews. So the search terms actually were chosen by Bhavin, which is the main author. And I mean, I would guess he must have used the terms which come more often in this field, but I don't really have experience in choosing terms for a systematic review, and I would be at a loss choosing terms for making a systematic review on this topic, because the topic is too vast in itself. And if you try and be systematic on a topic like restoration of endodontically treated teeth, you get obviously lost. And I mean, to be even more precise, I would say that we need also to be careful in this topic and in general in endodontics when you look into systematic reviews, because they provide lots of very interesting data, there is no question, and you can make a good use of them. On the other hand, you find very often some vaguely grotesque results from systematic reviews, because you just realize that they have followed all the process which needs to be followed for a systematic review, but clearly they have missed their main objective, and they, for example, choose the term correctly, but can't read the paper correctly, because this topic is complicated by the fact that there are so many different branches involved. There is the element of the endodontics, there is the element of the restoration type, there is the element of the dental materials involved in the restoration. So one has got to be extremely careful in evaluating this data, because the level of evidence on one side in a review like this is not very high. On the other side, in a systematic review, which is in theory would have a very high level of evidence, in reality provides no information for a dentist.
Oh, thank you very much. Actually, in your some of the previous reviews that you did, I saw the search terms, and there are a lot of search terms.
Yeah, that's the problem.
I was very confused as to how you actually.
It is confusing, exactly.
Yes.
So I cannot add anything to the fact that it is a confusing topic.
Yes, definitely. So we're going to continue with the second part, which is the structural and biomechanical challenges of restoring root-filled teeth. So actually, we all know that the loss of sound tooth structure is the most critical contributory factor. But in like 2 or 3 paragraphs, you actually discussed about the water content within the dentin matrix, and how the tooth actually loses this water content when it's root filled. So I'd like to hear your opinion about this. So is it really the thing that the tooth gets brittle after root canal treatment? What do you think about that?
I mean, it's a very good question, and we don't really know what is the most important part in making the tooth brittle. I mean, we all assume that the most important part, and it's a very reasonable assumption, is the loss of tooth structure, and we all assume that the contribution of the loss of water coming from the root canal treatment is not that important in determining the survival of the tooth. But yet again, there is no evidence to support clinically this consideration. And also from a clinical point of view, it's irrelevant. The endodontically treated tooth is the endodontically treated tooth. Either you decide not to do the endodontic treatment, which is an option these days, and then you can decide if you've got an irreversible pulpitis, not to do a root canal treatment and do a partial pulpotomy or a full pulpotomy. In that way, you've got an argument to preserve the vitality of the pulp and the humidity of the dentin. But the moment you decide to do a root canal, the discussion as to whether there is a loss of water or not is purely academic, because we don't have any way of restoring the content of water of the tooth. So this is one of those topics where people have been debating for a very long time and doing some interesting and less interesting research work. But the clinical implication is substantially very small.
Yeah, but Francesco, the problem is I have received also this question to me from the participants, and they're worried about some of the sentence in your article. You directly address that and say that root canal treatment is going actually to make the tooth weak, which
sorry, can you find the statement where it is? So
yes, I will do that while Fatima is carrying on. But the question is actually, what is your opinion? Because when you mentioned that we can use vital pulp treatment to save the humidity of the tooth, still it means that you believe that removal of the pulp tissue may tooth dehydrated. Do you believe in that, or do you think the hydration of the dentin and cementum comes from the periodontal tissue rather than the pulp tissue? What is your opinion? I may ask others also to give us their opinion as well about that. But according to the article, we are a bit confused about this. What do you think?
So I'm not sure which part of the article you're talking about. The fact
I
that,
will find it out for you.
so the fact that you're saying very different things. So the fact that the root canal treated tooth is generally speaking considered to be more fragile than a non-endodontically treated tooth is something which is supported by some evidence, mostly retrospective studies. For example, retrospective studies on partial coverage of root canal treated teeth and partial coverage of vital teeth, and it's been seen that the partial covered root canal treated teeth survive less. So if we say that they are more fragile because they survive less, then it's fine. If we say that they are more fragile because of the loss of water, we don't have any evidence to show that they are fragile because of the loss of water. So that's the situation. So the evidence is very weak in this respect. It may well be that in the future, and we are doing something in that along that line, probably hopefully publishing soon. It may well be that in the future we find that
nanoparticles.
So some other stuff is coming out now. So basically, what we might find in the future, and there is no evidence for the moment to prove it, is that actually the loss of tooth structure itself is the more relevant point, irrespectively of the fact that the tooth is root canal treated or not. So, for example, there is a large amount of misunderstanding where people think I do a pulpotomy and then I avoid covering the tooth with a crown. Actually, even the tooth with a pulpotomy covered with crowns survives more than the ones not covered with crowns. So this is where we stand. We stand in a ground where there is not much evidence, but the evidence we have, weak as it is that the root canal treated teeth, they tend to survive a bit less when they've been looked retrospectively than the vital teeth. But this reduced survival may well be due to the fact that they are a bit more destroyed than the others, rather than due to the fact that they are root canal treated.
Yeah, that's great. I think you already covered that. But Vladimir, please go us and tell us your comment. And others, if you want to add any comment, please just raise your hand and talk.
Yeah,
Vladimir, please.
I would like to add to this dehydration of tooth. But what is in practice that most of endodontic practitioners are using high percentage of sodium hypochlorite to remove organic debris and for a longer time with a higher temperature, but nobody studied does this high concentration warmed sodium hypochlorite it destroys collagen matrix. So the more the root is with more inorganic material, so it will be more brittle if we really overdo it. Irrigation with high percentage 5.2, I think it's really destroying and making the root, not the whole, the root more brittle and susceptible to fracture or to cracks.
Yep,
So
thank you very much. Yeah, Paul, please unmute yourself. Yes,
Well,
please.
it was also mentioned in the article that the proprioception of the tooth is reduced if you remove the pulp content. Of course, you still have the periodontal ligament proprioception, but I think that the patient with an endodontically treated tooth is biting harder or in an unconscious way on those teeth than on a normal vital tooth, and that occlusion, as was also mentioned in the article, is of paramount importance in the survival of the tooth. So occlusion and proprioception and sudden overload can induce micro cracks and vertical root fractures. And because a vital tooth has a pulp space, which is a volume which is, it's not empty, but it is a volume. While an endodontically treated tooth, when you restore the tooth conveniently and also the intrapulpal space, you fill it up with composite materials and flowables and whatsoever, and then a coronal access filling. So normally the coronal part should be even stronger than a normal tooth because by volume it is more densely filled than a vital tooth with only a pulp chamber in it.
Paul, what do you think about the proprioception? Do we believe that we have proprioceptive nerves inside the pulp tissue, or it's just in the periodontal tissue?
No, it's also in the pulp tissue. Not
All
only
right,
in the periodontal.
I think this is one of the challenging topic. Let's ask others as well what they think. I think Dr. Ahmed Hamid and Professor Hamou is going to, Professor Hamou, please go ahead.
Thank you for joining here. I'm so sorry I came late, but I need to answer one question because all my students, all my followers are asking always. We were discussing with Steve Cohen, and he said all posterior teeth should be crowned after root canal treatment. So I want to know your opinion about this, and that's it.
Okay, so this question also, please, Francesco, what do you think about the proprioception? Because I think there is a debate about the presence of the proprioceptive nerves inside the pulp tissue, and there are some articles that they concentrate this on the periodontal tissue, which means that endodontically treated teeth, they already have this proprioception. What do you think, Francesco, and maybe others as well? And also the question that received from Professor Hamou. What do you think about both?
So on the question of the proprioception, I mean, I am certainly not an authority on pulp or periodontal ligament histology or biology. So my knowledge comes from reading the literature. So I really can't add anything to what Paul said. I tend to agree with Paul and I tend to agree with the old experiments. I mean, there is no question that, in my opinion, it's just my gut feeling and the feeling from the old works that has been done on this topic, Lowenstein and Radkamp, all the other works that were works we cannot do anymore. No, overloading an endodontically treated tooth leads to a higher pressure. So these kind of things are there. And to me, they provide enough evidence to what Paul was saying, so that we tend to apply a bit more pressure there. On the nature of the proprioception, really, I'm not an authority to respond to this question at all. For the topic of the coverage of the posterior teeth, again, the evidence on the coverage of posterior teeth is obviously it is there. There is plenty of prospective studies and retrospective studies showing that there is some evidence that the teeth with crowns, they tend to survive a bit longer. Having said that, I mean, if you got a simple, small occlusal cavity in an unfortunate molar, which was exposed and has become necrotic, and you do the root canal through a very small occlusal cavity, do we really need to put a crown straight away? So the evidence there is there. I still think that there are a few small number of exceptions in which in a sensible patient, one can say, look, this tooth is so very little broken down that actually doesn't need the crown immediately. We may review it in a couple of years. So we published a work on not very broken down premolar back in 2012. And at 3 years of distance, it's a short time, the ones which were not covered with crowns were still there, more or less. So general evidence is, yes, you cover them with a crown or with an onlay, they survive longer. there are exceptions when the loss of tooth structure is really small, or the occlusal load is not that big, or the tooth is not very much opposed or unopposed. So as everything in dentistry, you take the evidence with a pinch of salt when you act.
Actually,
Okay.
I've got the questions. Some of them actually you covered already.
Fatima,
But
before you go ahead, let us ask Dr. Ahmed Hamid Ali to give us his comment. Dr. Ahmed, please go ahead and ask your question and give us your comment.
Thank you, Dr. Nokefar, for your invitation. Hi, Professor Mannocci. It's Ahmed. It's your PhD student. How are you?
Fine.
Yeah, thank you. My comment is there's many studies that compare minimal invasive access cavities with traditional access cavities, and they found no difference between in the fracture strength between the two access cavities groups. This can give us a clue that loss of tooth structure is cannot affect the survival of the tooth. Even these are fracture strength studies and not survival studies, not in the human mouth even. I think dehydration of dentine can significantly affect the survival of teeth. I think that the right answer for this question is to conduct a study that compare pulpotomy, complete or partial pulpotomy, with root canal treatment and see the restorative fractures or restorative failure that can happen during the course of observation. So that's what I think. This is just my opinion, and thank you very much.
Okay, Filippo, Professor Zimet, please you go ahead first, and then we ask Francesco.
With regard to fracture, are there two fractures that we need to think about? The first is those fractures that occur due to coronal fracture, which are affected by the coronal restoration, and then relating to what we were just discussing now, which is root fracture, which is seems to be a separate topic, which is independent of the coronal restoration. So how we restore a tooth coronally will affect one issue, but won't have an impact on the second issue, that is the vertical root fracture. What are people's thoughts about that?
Okay, Francesco, please.
Yeah, they're all very good points. I mean, comparing a full pulpotomy with what Ahmed is saying is a good point. Comparing a full pulpotomy with a crown and a full pulpotomy and a root canal treatment with a crown, and see if there is any difference in survival. The problem is that in order to do a study like that, what you need is a sample size which is gigantic, because if you put a crown on top of a molar with a with a pulpotomy or with a root canal treatment, the tooth loss which you can expect at 5 years is something in the region from all the studies we have of 4%. So if you got this kind of tooth loss, in order to find the difference between the two procedures, you would need millions of teeth. The problem is probably would be more easily solved in the long term, looking at large databases of cases, if and when the pulpotomy becomes a commonly used procedure. Then in 10 years' time, we can see if there is any difference in survival, and this would tell us something about the dehydration of the pulp. The argument made by the professor about the fracture of the root is very important. No, they are very different type of fractures, the root fractures. So what can we do to prevent those? I mean, there are teeth which show root fractures very easily. Typically, every endodontist know that you find root fractures in lower incisors in numbers which are much higher than fractures in other teeth. It's a difficult point, the proper fracture of the root compared to the fracture which is originated from the crown. So I don't think I've got any evidence, any clinical evidence to support this topic, but it is an important one. There is no question.
Thank you very much. Fatima, please carry on.
So actually, we talked about some of the contributory factors, such as the proprioception or the rehydration or dehydration of the tooth. And what I didn't actually take in account when I'm doing root canal treatment was the location of the tooth. And you actually discussed about this in the article, and it's one of the things that I didn't actually give a thought about, because you mentioned that if the tooth does not have a contact with another tooth, then it's more likely to fail in a long term. Now, I couldn't actually quite say that, but if it's an upper 6 or an upper lower 6, it has all the corresponding teeth. But if it's a 7 with nothing behind it, then it's more likely to actually fail in the long term. So
Yeah.
what I want to ask you about how actually this location matters.
Yeah, it's another very good question. I mean, if there is one thing of which we have a very, very strong evidence about historically and in more recent works, there is one thing we know for sure is that the 7 survives far, far, far less than the 6. So there is no question about it. Whether it is because it becomes a terminal tooth in the arch, whether it is because the root canal treatment appears to be more challenging and there are more failures. I tend to believe that it's the fact that obviously being more frequently the terminal tooth in the arch is more heavily loaded. But there is plenty of evidence that the 7 and in general the teeth with no adjacent tooth, they survive far less than the others. The reason can be discussed and all the hypotheses are open, but there is no question about that. So the last tooth in the arch, the 7 or the 6 which become the last tooth in the arch, or the 7 without the 6 at the front, or the 6 which is the last tooth in the arch without the 5 at the front, they survive far less than the others. The literature is full of very strong evidence on this, very, very strong.
And it was the first time actually that I came across with that. And thank you very much.
Fatima, there is a comment by Professor Mohammed Hamoud. Professor Hamoud, please.
Can we make a recommendation for dentists if one of the marginal ridges of lower molar is missed after root canal treatment? Let's go for a crown rather than for adhesive materials.
I mean, it's a sound it's a sound advice. I mean, the thing is,
do you have enough evidence for this?
That's no, obviously we don't have enough evidence to make that precise statement. The problem is, again, we need to take the evidence with a pinch, especially when it's not very strong, with a pinch of salt. So we've got dentists, general dentists in general, and all the endodontists know this, that you tell them put the crown on the tooth, the patient goes back to the dentist asking for a crown on the tooth, and the dentist doesn't do it because he wants to wait and see the outcome of the treatment. So any guidance, explicit guidance we can give them in order to facilitate the placement of the crown, I think it's welcome. But obviously we can't really say that we got evidence about that particular topic. But I mean, I would agree with the colleague. We should say that. Definitely.
Thank you. Fatima.
Well, actually, we kind of discussed about this, what to change when dealing with a root field tooth versus a vital tooth. So I got a second question, because I know that you also had a review about this. What to change when dealing with a retreated tooth versus a primary root field tooth?
Yeah, I mean, it's obviously it's a very vast topic. First of all, again, we need to split the thing. So if you look at the classic literature, so the classic studies, for example, the ones we have done, or the ones that been done by Kish Gulabivala, which are very well controlled studies in a clinical environment, or even studies done in private practices, well controlled. then it appears to be that there is no real difference in the survival between endodontically retreated teeth and primary treatment. Actually, if you look at the data on large studies, again, the large database study from Korea, for example, or also from America, when you start looking at millions of teeth, there is a difference. The re-root canal treated teeth survive much less, let's not say much less, significantly less than the primary treatment. So clearly, the re-root canal treatment is a tooth which we need to tell the patient has got a smaller chance of survival, or a smaller proportion of survival at 5 years or 10 years compared to a primary root canal treatment, and the patient understands that. In terms, there are certain groups of re-root canal treated teeth in which the survival is extremely good, and we all know which these teeth are, and we found that in our trials. Is basically the molar which has got enough tooth structure left, so it's not too broken down, and the molar which has a re-root canal treatment which is not associated with irreversible damage, as I say, a lateral perforation, or a perforation at the apex, or a blockage of the canal. If those major mistakes are not there, then the endodontic outcome and the survival, provided the tooth structure is enough, then that kind of retreatment has got, in all likelihood, almost the same success rate as a primary root canal treatment. But in general, particularly when we talk about molars, we need to say that those teeth will have a smaller percentage of survival at 5 or 10 years compared to a primary root canal treatment. So this has to be admitted, that it goes a bit against the normal idea of the endodontist, which tend to tell people is they survive as much as the primary. You know, they don't survive as much as the primary, but they are still worth keeping because they still function, generally speaking, better than an implant as long as they function.
And you also mentioned something about enough tooth structure. So I would like to discuss a little bit about this enough, because I read that 30% of tooth structure can be considered enough. So how do you define enough?
Yeah, obviously, it's a very good question. That particular study was using, obviously, a scanner to measure the residual volume of the tooth structure. And so that in that particular study was found to be the threshold beyond which there was a much better survival. So again, that 30% obviously would be measured with a scanner. If someone has got the time to do it, then it is a good indication. But generally speaking, one needs to think that the more broken down the tooth is, the less are the
chances of survival.
Chances of survival. There may be no difference in outcome, because if a tooth which is very broken down, one may think it's got a better outcome. No, actually, it's got a worse outcome, even endodontically speaking. So that fact that it's broken down is difficult to argue, to think about possible reasons. But the broken down tooth, we know from the retrospective study that will survive less if it's retreated. The very broken down retreated teeth tend to survive less than the others. And we also know that the primary treatment, or the secondary treatment, actually, the retreatment of a tooth which is very broken down, tends to have an outcome which is worse than the re-root canal treatment of a tooth with a lot of tooth structure. So again, we are going back to square one. The amount of tooth structure seems to affect not just the survival, which is obvious, but also the outcome of the treatment, which in turn will reduce the survival.
I think Dr. Noor has a question.
Sorry, if we go before we ask Dr. Noor to tell us his question, if we go back to what Professor Zimmet mentioned about the fracture of the root, comparing to the coronal part, back to the secondary treatment or retreatment, I think we remove more from the radicular part of the tooth during the retreatment. Do you think is there any relationship between this as well, that maybe with the secondary root canal treatment, we may have more root fracture comparing to the coronal part? What do you think, Francesco?
It may well be the case. It may well be the case. Clearly, it's a very good point. Very often, when we do re-root canal treatments, we feel the need, and it's human, no? Because you've got a root canal treatment which fails. It has the root canal you see is not being prepared very much. You tend instinctively to increase the size of the preparation. And if you do increase the size of a preparation in the mesial root of an upper 6, of an upper 7, or in the mesial root of a lower 6, of a lower 7, those roots have got obviously a very small distobuccal diameter. And what are we going to do? We are going to crack the tooth, and if we crack the tooth, then the tooth may well be lost. So that's something we need to keep in mind when we do retreatments. Do we always need to increase the size of the preparation? Because this is what instinctively people tend to do. We need to think about that might affect the survival of the tooth by increasing the chance of cracking the root or propagating a crack which is already there. And then we'll put a crown on that tooth, which maybe up to that point didn't have a crown. And then maybe up to that point had a feeling that was worn down. And then you put a crown which is made of a full ceramic. And then maybe the crack propagates. So there are a number of question marks, but certainly your objection is valid. No, we re-prepare too much, we crack the tooth.
Okay, thank you. Dr. Noor, please.
Okay, thank you so much, Dr. Nico, for inviting me. I really appreciate that. I have one question, really important. If the patient will avoid to do crown after root canal treatment, and he came after a while, and his filling is full down. Some of his filling is broke. And he said, let's do again, like filling material. He don't want a crown. He wants again to do filling material.
Dr. Noor, we cannot hear you very well, but Francesco, if I understand Dr. Noor, the question is if the patient doesn't want or deny receiving the crown and then the restoration failed, and again, they want to refilling the tooth. Is this any effect, or can we do that, or anything like that? So patient desire, let's call it patient request or patient desire, the effect of that.
I mean, it's clearly it's something that's the reason why I did originally these studies on without crowns in my practice many years ago in Italy, because I had lots of these patients, because in Italy at that time and even now, there wasn't very much public dentistry. So many of my patients could afford the root canal, but they couldn't afford the crown, and they were delaying the crowns. Clearly, if the patient doesn't want to have a crown done, in my experience, when the tooth fractures, then at that point they would want a crown more often. But clearly, if you are relying on direct restorations, the only advice one would give is to try and cover the cusp, even with the plastic material, the composite, obviously, because I mean we don't use amalgam anymore. I'm not sure if there is any in the audience which still use amalgam, but if the patient doesn't want to have a crown done for economic reasons or any other reason, then the only solution to prolong the life of the tooth, in my opinion, not there is much evidence on that, is to try and cover the cusps with the composite as much as and have a full cuspal coverage with composite.
Thank you very much indeed. Okay, Fatima, please carry on. And I'm happy to see some face of some of our colleagues that they are prosthodontists, that they join us as well. So if they want to add any comment, please just raise their hand and then we ask them to talk. Okay, Fatima, please carry on.
So the next subheading was study heterogeneity and challenges for research relating to the restoration of root-filled teeth. And again, it says that the lack of well-controlled prospective studies And also because it's difficult to quantify and standardize, as we talked about a few minutes ago. So there is also an editorial about the elephant in the room from Professor Mannocci. I read about that because we kind of tend to ignore the elephant in the room, which are the effect of occlusive factors, and because these factors are poorly studied, unfortunately. So, yeah.
Well, the problem with the occlusal factors, that they are poorly studied, and that's not the endodontist's fault. The problem is that there is very little standardization in terms of what is a normal occlusion, what is the normal level of tooth wear, what is the normal level of tooth structure loss due to erosion, due to abrasion. So all these fields, which obviously must affect the survival of the teeth, we don't have a standard to say what is a normal occlusion, what is the normal level of erosion, of abrasion or attrition that we can get in a patient at a certain age. Because I live in a place, I mean, just around the corner here, they study erosion 24 hours a day. But when you ask them what is the normal level of attrition, of erosion of a patient, they don't have a standard. So here we are really very much behind, because it would be like treating hypertension without knowing what is the normal blood pressure level. Now, at least
That's a good metaphor.
At least the doctors have established somehow that a normal blood pressure level could be 110 out of 80 or out of 70. If you ask David Bartlett, which has spent his entire life studying erosion and abrasion, they can't tell what is the normal value. So and the same applies to the occlusion. What's the normal occlusion? So there isn't data there to start from.
Okay, Paul, please.
Yes, you stated that occlusion is so important for the outcome studies of endodontically treated teeth. And often in clinical studies, authors do not pay enough attention to the occlusion parameters. That's what you also mentioned. Do you think that in clinical studies, the use of the T-scan, for example, should be included, as it allows you as well to have qualitative as quantitative data about the occlusion? And if you combine it with an intraoral scanner and you map those data, you can perfectly analyze occlusion tooth by tooth and include it in your outcome studies.
Yeah, I totally agree. We have that could be the best route altogether, no, because you will have your own controls. So it's I totally agree with Paul. That would be the route forward. That there's no question. There's no question about it. The problem is that the people that classically think about occlusion, I don't know, they are somehow they tend to be suspicious towards scans and scanners. No, but that's the way you can see things. I totally agree with Paul.
The reason why I mentioned this is we see more and more external cervical root resorptions in teeth which are overloaded and have hypoxia in the periodontal ligament. And when you then insert a T-scan wafer and you analyze the occlusion, you are highly surprised that those teeth with external cervical resorptions are the ones that have a traumatic occlusion at the same time.
Yeah, it's an extremely good point. I think you've spotted one right aspect there. There's no question.
Okay.
Paul, can you give us some more explanation of your opinion about it?
Well, occlusion, it should be a very nice balance. And I see in a lot of patients that underwent orthodontic treatment that all those teeth are well aligned, but are not well in balanced occlusion. And the patient starts to grind and to brush in order to bring that occlusion into balance. that, for example, in combination with the orthodontic treatment and the hypoxia in periodontal ligament are already two factors that can induce external cervical resorption. So orthodontics and malocclusion. And that malocclusion in endodontically treated teeth could increase also the bad outcome of because of fractures and that can be induced.
Yeah, that's great. Correlation of orthodontic forces as well can be a very good topic to discuss, because we are going to discuss such a thing in our future program as well. Thank you very much for the comment. Is there any other comment, any other question? Okay, Fatima, please go ahead.
Okay, we already discussed the limitations of a clinical study aiming to address the tooth longevity, so I'm going to pass it. So we're going to start with the current perspectives on residual tooth structure. First, it's the ferrule effect, the thing that most of the undergrad students have no idea and cannot understand a lot about, the ferrule effect, but it's obvious in most of the studies that the survival increases with ferrule effect. And the actual surprising part is that evidence for the benefit of the ferrule effect in premolar teeth, it's not possible to draw such strong determinations for molar teeth, it says. So the ferrule effect actually differs from the premolars to the molars. So I'd like to direct this question to Professor Mannocci as well. What is the difference in between?
Yeah, no, it's a good point. I mean, the evidence has been found mostly on premolar. It doesn't mean that the ferrule is not good in molar. The strongest evidence is in premolars, but if you are doing a crown, having a ferrule effect on a molar is probably equally effective, even if the evidence is not entirely there. What one may say about the ferrule effect is that because some people is like I mean very strict on that, no, and you find that people that say, okay, we need to extract the tooth because there is a millimeter missing of ferrule effect out of 10 millimeters or 11 or 12 or whatever it is of the circumference of the tooth. So one has to think with a pinch of salt. Clearly, in a premolar is more easy to demonstrate, and it's being demonstrated, but the ferrule is important also in the molar. If you don't have a ferrule in a couple of millimeters, and that ferrule is a bit shorter than what you want, maybe 1 millimeter or 2 millimeters, that doesn't mean that the tooth needs extraction. So and also the whole discussion on the ferrule, I mean, is becoming possibly a bit less relevant now, because now people use a lot of partial crowns, and so the question of the ferrule, it obviously only applies to full crowns. So now we are using techniques which are less destructive, but if you are doing a full crown, then the ferrule is obviously a good thing. I mean, there is all the evidence in the world to about that.
Okay.
I think we got a question.
Yeah, please.
Dr. Hissam, please. Unmute yourself.
Yep, Dr. Mimamadi, please.
We still cannot hear you.
Yeah, Hissam, please unmute yourself and talk.
Yes, I did.
Yes, yes, we can hear you now. We can hear you.
Hi, everyone. Dr. Mannocci, I had a question about ferrule effect, because everywhere we read about the height of ferrule, but about the thickness of ferrule, what I miss is the thickness of the ferrule. Because when we have like 2-3 millimeter ferrule with like a 0.5 millimeter thickness, does it make sense to keep the tooth, or we need to have also data about the thickness of that ferrule?
Yeah, no, it's a very good objection. Clearly, I mean, if the thickness is insufficient, then everything crumbles. There is no question about it. So that weakness in the evidence is there. There's no doubt about that. All the studies which have proven this kind of things have been done with teeth which were not that much broken down in that respect. So yes, the thickness is very important. There's no doubt about that. If there is not enough thickness, then you need to think about either you want to you can try crown lengthening as much as you can. You can try orthodontic extrusion if you like doing it. It's a very elegant way of doing things. In premolar, for example, may take a bit of time, but it does work at times. But yes, definitely the thickness is crucial. There's no question about it. And there is not much evidence on that. There's no question.
Yeah, thank you. But which thickness do you recommend?
That's the problem. I mean, if you talk about a clinical recommendation, my first recommendation, as everybody else, would be if you can avoid the full crown, avoid the full crown, and don't have this problem. The second recommendation, that there is no fixed thickness, obviously, because if that particular margin is very thin in only 2 or 3 millimeters, then of the perimeter of the tooth, then you can easily do some tiny crown lengthening, or if it's lingual, you can even do a small gingivectomy and remodel the bone a tiny bit and get a bit more thick. I would say that the thickness you need is the usual couple of millimeters, a millimeter, depends on the type of restoration you want to do on the tooth. But certainly I can't give you a fixed value. That's the safe thickness of the ferrule, because I wouldn't be able to tell you that.
Thank you.
Thank you very much, both. Fatima, please. We have 25 minutes from now, so please manage it.
Okay, I'm going to just pass this part fast, because we know that the number of residual walls is very important. And if the teeth has no or one residual wall, then it's obvious that they have reduced survival rates. And the other part is the remaining tooth volume. Now that we can actually calculate the remaining tooth volume by using the intraoral scanners. And again, the future research should be directed towards the remaining tooth volume. So I'd like to discuss a little bit about the dentin substrate modification and adhesive bonding, because it's actually right now the biomimetic dentistry is very hot topic in vogue, and people are discussing about the adhesive techniques. So there is a confusion about this. So I'd like to ask Professor Mannocci's personal opinion about the bonding techniques, because there are too many options available now on the market.
Yeah, I mean, it's true. It remains a very confusing topic, particularly when you talk about root canal treated teeth. Because I mean, if you stick to vital teeth, there is quite a lot of evidence that the classic 3 steps they tend to work better than the others. So obviously, it all depends on the type of restoration you are having. If you are restoring a premolar and you don't need any post, a 3-step bonding agent remains the best option. If you don't need post placements, then I would stick with a 3-step bonding agent. That's my personal preference. Although, for example, here guys they all use 2 steps, and it's almost impossible to convince them not to do it, because they do it for infection control reasons. But there's no question that the 3-step they are better. There is plenty of evidence that they are better. If you're talking about post placement, it's a different story, because the post placement doesn't lend itself very much to the 3-step bonding procedure. So clearly, if I have a post to place in a premolar, for example, which we do very rarely, but we do need some posts sometimes, not very often, because I mean, with the postgraduates, I may place a post, I don't know, probably 3 or 4 times a month maximum. So it's something that we do less and less. But for a post, I would rather use a self-etching primer in the root canal and then use a 3-step bonding agent on the crown. This is my personal preference.
So since you have mentioned about the post placements, actually right now the biomimetic dentistry goes to the point where no post is best post. So I'd like to also address this. You're also mentioning that we are doing less and less posts recently. So it's good to hear the confirmation of it too. So you also mentioned about the stress absorption by cavity liners. Most of these cavity liners are glass ionomers, the resin modified glass ionomers. And you also mentioned about the air abrasion using titanium oxide. And also one of the factors that most of the biomimetic dentists are now doing is the use of chlorhexidine. So just putting the chlorhexidine right after doing the root canal treatment to enhance the bonding. What's your opinion about that? Should we keep on using it, or?
I don't know. I mean, to be honest, I'm not an expert of that, because clearly we are collecting data on the literature. I've never used chlorhexidine for this purpose, but in the literature and in the research around, there is a lot of it. So we did mention it, and we did describe the literature behind it. But to be perfectly honest, I've got no experience in using chlorhexidine in this. There is all the scientific background for using it, but it doesn't belong to my experience at all. So I really cannot comment. We are just reporting the literature there. The glass ionomer is a different story, no? Because the glass ionomer is a clever material, and it's got its role sometimes. No, it's difficult to tell because no one has really ever tested very well done glass ionomer or sandwich techniques as a base for a core. But I mean, the glass ionomer has got its own advantages. It's a smart material. No, when it cracks, or if there is some infiltration under the crown, it expands a bit and then it contracts a bit. So it does act to a certain point, to a certain extent, as a buffer. So that's another field which is probably not being studied very much in endodontics. Talking more about conventional glass ionomer than resin modified glass ionomer, to be honest.
So when we actually started doing the discussion, your PhD student actually said that minimal preparation does not have a significant advantage over the traditional cavity preparation. So you also mentioned, okay.
I'm not sure about that. There's no evidence that obviously if you reduce the access, that is one thing. The size of the access cavity in relation to survival, it needs to be studied. So what is surprising, I'm open to any suggestion, and I'm open to any conclusion if a study comes up. But if nobody ever tests the success of the survival of a root canal treated tooth with a small cavity versus a root canal treated tooth with a normal cavity, what are we talking about? Because I mean, if you look at this kind of access cavity that people show, they are really very small, and so there is little doubt that if you can do a root canal with that kind of small access cavity, and then you decide not to do a crown, then probably the tooth will survive longer than a tooth with a larger access cavity and no crown on top. But no one has ever tested this hypothesis, and no one has ever tested the hypothesis of the same access cavity a bit bigger or a bit smaller with the same crown on top. So, I mean, these people which are so fierce about reducing the access cavity size, which is a good thing, they should be brave enough to do at least a small study and see how it's gonna go in comparison to a conventional access cavity. Because on one side we have the reduced loss of tooth structure, which is good. On the other side, we've got the chances of not accessing well, not cleaning well the entire root canal system, which is not as good. And most of all, there is also a problem, a political problem, if you want, that we've got to teach students how to do things. And obviously, you can't really teach minimal access cavities to someone that is not able to use a microscope. Because obviously, an undergraduate student in no school in the world comes out at the 5th year or the 6th year or the 4th year of the dental school and is competent in using a microscope, because it's impossible. Yeah. So that's the problem. So there are a number of problems about small access cavities.
So you also mentioned the optimal bonding may be more relevant. And so we all know that it's important. So that was actually going to be my question, but you already answered the question.
Sorry about that.
Yes.
Let's listen to what the other things. I mean, I think that there are lots of people which are experts on this here.
Yeah, is there any comment about the previous question from our professors and colleagues that they are here? Is there anything that anybody wants to add to it? Okay, okay, Paul, please go ahead. It's good to hear from you. I can see you in the chat box. You mentioned something. Please.
Yeah, in the chat box, I mentioned 2 articles about the pulp innovation and the feedback that the pulp can give in case of overloading. So one is in Brain Research and one is in the Australian Dental Journal.
Thank you. Thank you.
And concerning the discussion, I agree with Mannocci. There is no evidence that minimal invasive ninja cavities and so on will improve the outcome of root canal treated teeth, because it has also a negative drawback, because your irrigation is less effective, your mechanical instrumentation is less effective, you have more risks to miss hidden canals, and also the obturation, it's not always evident. But there are no controlled studies that can state that ultra small cavities give a better survival of endodontically treated teeth. There are other things that make things more complicated, and we have to be careful that it's not mixed up with the goal we want to treat, to obtain. It's the strength of the tooth.
That's great, because there is a trend actually in especially young endodontists to use this minimally invasive endodontic cavity preparation. Professor Al-Hawaizi, I know you have a lot of restorative experience as well. What do you think about this question?
Well, really, first of all, thank you very much for this event. You really pick very clinical and nice topics. And it's very nice to have Professor Mannocci with us. Concerning minimal invasive endodontic cavities, really, I have to think of it as a whole. It's not just decreasing the size and so that the fracture would be less, but really, I totally agree with my colleagues. We had so many researches about retreatment and the instrumentation. All these things, they, if not done well, they will be affecting the prognosis of our treatment. So I really am very skeptical about this minimal invasive endodontic cavities. I may say when applicable, or if applicable, I make it as minimal as possible, but not to the degree of being so minimal that I can't manage proper endodontic treatment.
Okay, thank you very much. Professor Kazandek, what do you think?
I think, yes, so far we don't have enough evidence to prepare those contracted cavities to bother us to do that. However, instinctively, let's say, if I would have a root canal treatment, I would have I would like to have a contracted cavity. At the end, it would work. We know that. We don't have enough evidence now. I think that we need some guidelines. We need a conclusion like ALARA principles in radiology, as low as possible, as necessary. If do it, do the large cavity as large as possible. We have to reason what we do. I feel that in many cases, we don't need to open large cavities anymore because we have enough flexible instruments, we have enough illumination and magnification. However, we don't want to leave our habits. So I think in the scientific environment, we need a conclusion for clinician to adhere, like ALARA principles. This is what I think.
It seems a bit too early for the guidelines. We still need a lot of more studies and evidence. I also know that Hessam doing a lot of minimally invasive endodontic cavity. So Hessam, what do you think now?
Yeah, first of all, I have to say, yeah, I agree. Performing such a study will be very difficult because there are lots of cases I intend to do minimal invasive, but meanwhile, I have to open my access. So because I see that I cannot finish my treatment as minimal as I wanted. So I mean, those cases you see on Instagram, these things, they are some of
Instagram-friendly access cavities.
That just some of many cases that we try, or people like me try to do like that. So I mean, doing a study on that will be very difficult.
Okay, thank you very much. That's a good discussion. Actually, in Instagram, I have seen a case that the endodontist didn't use a rubber dam but did a minimally invasive endodontic cavity. And I add a comment and say that is a very small opening to billions of bacteria to the root canal system. So that's sometimes the problem. We forget the principles and we try to show off something. Great discussion. Thank you. Fatima, please.
Okay, the second part is the composite resin materials. Because the main problem with using composite is the gap formation. So I'm going to pass it quite fast because I want to come to the questions part. So this is the trendy topic, which is DME, deep marginal elevation. So actually recently for the last, I don't know, 3 to 4 years, I've been using the deep margin elevation. So the question is, where does deep margin elevation end and surgical crown lengthening start? So how do you decide on which one to do? Professor Mannocci.
Right. I mean, again, I don't think I'm an expert of deep margin elevation at all. I mean, I've done it. I do it. There's no question about that. The problem is, I mean, practically speaking, if you very often you start with the idea of doing crown lengthening, you think crown lengthening is necessary, and then I mean you do a good oral hygiene for the patient, you do some scaling and root planing, and then you realize that you place a temporary filling for a bit, and then you realize you don't need it anymore. So I think I mean there is no hard evidence on that, but it looks like a technique which has been working, at least in hands which can use it properly. Again, I mean, we don't have evidence that deep margin elevation could be as effective as crown lengthening or more effective than crown lengthening, but it seems to be a conservative way and a less invasive way of solving the problem. And again, I really can't see myself as an expert of this field. This is
what about comparing this to ferrule effect? So because that means we don't have ferrule for that.
Clearly, theoretically speaking, you don't have ferrule there, but I mean, it's not that you are deep margin. This goes back to what we were saying before. It's not that you're doing a deep margin elevation of 360 degrees. You're doing deep margin elevation in one small section of the tooth. So I think we need to add with a bit of common sense. I mean, the dentists who have proposed the deep margin elevation are very expert people that have spent their life doing these things. So it can be used effectively. it's the kind of things you will never have a hardcore evidence on that, but it seems to be working, and it gives many dentists a way of doing things precisely and without addressing the case with an excessively invasive procedure. I mean, this is really all I can say. But I'm sure there are people more experts than me in these people who have used it more than me. Maybe they can tell us something more.
Is there anybody here that they want to add anything to this topic? Deep margin elevation?
Actually, deep margin elevation is a concept that started with Professor Mannocci. And he mentioned that if you can isolate a tooth with a rubber dam, then you can do the deep margin elevation. So isolation is the key again, once again. So yeah. So I'll keep on going because we just have about 10 minutes or 5 minutes left. All ceramic crowns and onlays, I'm going to pass to the main question. How do you decide on full crown, full cuspal coverage, onlay, and the crown? Because there's a lot of confusion about it. And sometimes I freeze when I'm doing something on the patient and I try to decide which way to go. So as a clinician, I'm wondering how you decide on what to do on specific teeth.
Yeah, I mean, it's obviously is the question, the one very important question altogether. No, there's no question about it. I don't have this very large experience of on endo crowns. So the person that did the endo crowns on this is the section is Kerstin Bitter. So she's done many more endo crowns than I have done. They seem to be working well. So there's nothing wrong if you want to replace an onlay in a little bit more destroyed tooth with an endo crown. But generally speaking, I mean, if you can solve the problem with the partial crown coverage, is a good idea compared to a full crown. Clearly, I mean, if you go into large numbers, inevitably in a large study which compares onlays versus full crowns, you probably lose a few more onlays than full crowns, but the lost onlay most of the time can be replaced or replaced with a full crown. So generally speaking, I mean, if the tooth structure is enough, and I mean, in the practice where I work on Saturday, the vast majority of the teeth are restored with onlays rather than with crowns. And I think the same is happening everywhere. So it does make perfect sense. And clearly, I mean, the endo crown is a good alternative. You use the full crown when is not feasible to avoid the removal of that little amount of tooth structure left. But I mean, clearly the crown's kingdom these days is retreatments. So you do a crown when you have done a root canal treatment of a tooth. Maybe the tooth didn't have a crown before, but since it's a root canal retreatment, at the end of the retreatment is so broken down that you can't easily put on many endodontically retreated molars only. So generally speaking, I end up teeth having restored with crowns after a retreatment on molars more than primary treatment. The vast majority of the primary treatments are restored with onlay or endo crowns.
Thank you. Professor Zimet, please.
Does that mean that our vision of what we used to think of a crown as a ferrule to bind the tooth together, our vision of the stress distributions is very different now. And now we regard it as a dome, as the overlay is more important than the ferrule. And so does that mean we're changing our vision of the ultimate restoration of the teeth? So if we can rely on a dome effect, which has been described in the literature, it's far more conservative than removing a whole lot of extra tooth. Is that a new, not a new philosophy, but a reconfiguration of our philosophies?
So Professor, actually you're mentioning about the biorim preservation.
Yes. So if we maintain the cervical rim of tooth and preventing the pericervical rim of tooth, and we retain then we're distributing our forces to the cervical area, and we're changing our forces from a tangential force to a compressive force, and we're relying on the dome effect of the compressive force. Whereas before we used to say that the tooth had to have a crown so it would bind the tooth together. Is that, maybe that's not something we need to teach anymore?
It's a very good point. I think it's a very good point. What we can reasonably think, if you look at what we have in terms of long-term result, because also we got to think that these onlays obviously are not made of gold, they're made of different materials. So we need to tell this concept is valid. We need to get the patient to understand that instead of having this crown placed, which is gonna keep for, let's say, 15, 20 years, and then maybe the crown is removed and there is so much decay that the tooth needs to come out, they may end up having an onlay, which is gonna stay there maybe for 10 years and then maybe break or be replaced. And at that point, they will have the crown, and the crown will survive the other 10 years. So this, I think, is the right concept to say. So that dome effect is a very good thing, but clearly, particularly with the material we are using now, there is a chance that at some point that will result in the crack of that structure. No? So we need to think about the fact that that restoration is more conservative and will be replaced in the long term. If you take millions of teeth, it will be replaced a bit sooner than the crown, and then you will have the crown. I think this is what we can honestly tell the patients, or maybe I'm too old-fashioned in this respect.
No, that's great. That's great. Thank you very much. Fatima, is there anything else that you want to add, or can we close the session?
Actually, I've got so many questions, but since we have just 1.5 hours in this, I'd like to thank all the professors who joined these fruitful discussions. Actually,
yeah, thank you. You managed that very well. Your slides help us and guide us in a very good way. Honestly, every time that we ask you to do this job, you did it in a very, very good way, very great way. Thank you very much. And also, I should say that Professor Mannocci, you are a role model. Honestly, you are a knowledgeable man. You are very humble. I don't think you can also give us a lot of energy out of this topic, because always when we speak about restoration of endodontically treated teeth, Francesco Mannocci is attached to that. So we cannot remove your name from this topic, and you are very humble. And one of the things that I really learned from you was about saying something when you said that you don't know that. This is amazing. I think you taught our young fellows that when there is no evidence, or when you don't know something, you frankly said that this is not my topic, I don't know that. This is amazing. I learned a lot from you. I admire you. Thank you very much for accepting our invitation, being with us. Having also Professor Paul Lambert is an amazing also opportunity for us. Thank you very much, Paul, by sharing your knowledge with us. Thank you, all of you. I cannot mention the names all one by one. So please put our hand together for Dr. Fatima Betul Bashturk for giving us this very nice presentation and leading these sessions for us. Thank you very much, Fatima.
Thank you.
We always have
Thank you very much.
Support and your knowledge. Thanks for doing it for us. That was a great pleasure. Professor Francesco Mannocci, it is a great honor for me. Obviously, I should say that I'm not at this position to sign any certificate for such a professor like you, but this is my honor actually to sign such a things. Just as the moderator of the session, I don't have enough words to thank you, and thanks to all of our colleagues who joined us today. And sorry if I cannot mention the name one by one. Please ask your student to join these sessions. These sessions, actually, the goal of this session is to discuss. As you can see here, we just discussed the topic. We didn't go to the details of the technical things. So next sessions, we will discuss about the effect of the COVID-19 pandemic on the cracked tooth, which is published by Dr. Ali Nosrat and Ashraf Fuad in Journal of Endodontics. So in 3 weeks, I believe in the 19th of November, which is the Saturday, actually, because every 3 months we have Friday and we have Saturday sessions just for Eastern and Western time. So we will see each other in 3 weeks to discuss about the cracked tooth. Thank you very much indeed. And I want actually to ask Professor Paul Lambert to end the sessions because his presence today was a gift to our colleagues. Paul, please close the session by your talk.
Okay, so it's for me the first time that I take part of this session. I already got several of your emails that intrigued me, and next week on Thursday, I have a journal club with my postgraduates on the article of Mannocci et al. And so I'm very well prepared now to lead that session for the next week. And I also have added the 2 articles which I mentioned in the chat box, and I will send them as a PDF copy to your email, so then you can share it to the other people too.
Thank you very much indeed for joining us, and hopefully next time we can merge our journal clubs all together to have a sessions with all of our students and for a better discussion. Today was amazing. Professor Mannocci, the stage is yours for the last talk.
Oh, no, thank you all. It's been a pleasure being with you. And yes, you're absolutely right. I'm not an expert of everything. I mean, even in restorations, there are many people that do more restorations than me these days. So yes, I mean, it's a very confused topic, and the way is restorative dentistry. I mean, there's no way we can find something. It's not like say the Alara principles. Even the Alara principles. They are based on stuff which is not that sure. So same as the lady was right. We need to give some indications, but then we'll have to think about what we need doing case by case. There's nothing else we can do about it. So it's been a fantastic discussion, and been a pleasure to see Paul, you, and all the other colleagues there, which I've met in different moments in my life. Thanks
Thank
a lot.
you. Just to know that what our audience, some of our audience send it to us in the chat box. Super professional performance, bravo, well done. Please add reminder or alert for new meetings. Looking forward to next ones. Thanks for the rich discussion. Great meetings, excellent discussion. Thank you for this wonderful presentation and mind-provoking discussion. Good to see you, everyone. Thank you very much indeed. Thank you, and bye-bye.
All right.
Actually, we are going to have some video from our sponsor. Please feel free to go. If you want to stay with us and watch them.